So I'll go on to our next speaker. Our next speaker is Dr. DIGVIJAY SINGH, who has specialized in pediatrics, glaucoma, and neuro ophthalmology, and is practicing in his own center, the Noble Eye Care, after his stints in different reputed institutes. He has a rich experience of dealing with complex surgeries and has a special interest in diseases of the optic nerve and brain. He is going to be talking to us on managing fourth nerve palsy. On to you, doctor.
Thank you, Dr. Amurthy, and it's a pleasure to be a part of this session. So without further ado, I'll shift to managing trochlear nerve palsies. Is my screen visible to everybody?
Yes, you can go on.
So, we've already discussed the third nerve palsies, and Dr. Randhir has already covered very nicely how to manage situations of cranial nerve palsies, particularly where diplopia is involved. So, trochlear nerve palsy is no different in terms of the presentations of double vision. However, the kind of double vision we get is different. So, I'll come to the finer points, the specific points for trochlear nerve palsy, not to have repetition of what's already been discussed. The first and foremost thing is the trochlear nerve anatomy. So the trochlear nerve, or the fourth cranial nerve as we call it, is the longest cranial nerve, and it's got about 75 millimeters long. It comes, it is coming out dorsally, and it is then crossing over completely towards the other side, and it is at the level of the inferior colliculus, and then it travels down the lateral wall of the cavernous sinus and through the superior orbital fissure into the orbit, and where it is innervating the superior oblique muscle. So all postgraduates must be aware of the neuroanatomy. It's a very important thing, because based on just the neuroanatomy alone, you can predict where the lesion would be if you find certain clinical signs and symptoms. So for a trochlear nerve palsy, the important points in history that you want to look at, of course, the presenting complaints will be double vision or diplopia. You will have a squint which is present. So there is a hypertropia. The eye is generally upwards. So somebody would say that the eye has gone up. You'll have a head tilt, which is a more common thing that people actually notice, or somebody else other than the patient himself notices. And you would have asthenopic symptoms of eye strain and mild palsies, and sometimes neck pain because of a persistent head tilt. Some of the questions that you must have, particularly asked if you're asked in the exam also, is whether the double vision, is it horizontal or vertical, or whether it is also torsional. So specifically ask for this. Ask the patient if they're having difficulty climbing downstairs or having difficulty in reading. Because again, these are cases where the superior oblique works best, and if it is paralytic, then you'll end up with diplopia in those positions. You do, of course, want to ask about, certain other histories as well, such as systemic histories. And, just like other things, diabetes, hypertension, cardiac events are associated with trochlear nerve palsy, though it is a lesser cause. A more common cause is trauma. And in cases of head trauma, even closed head trauma, which may appear mild, trochlear nerve palsies are often noted. Sometimes they would be congenital. And in those cases, you want to look at a family history, because you can get an autosomal dominant pattern. In the examination, the first thing that you must always say is that I will examine the head posture of the patient as he's entering the room, because I want to look for the head tilt specifically. And you also want to look, in case you're getting a congenital superior oblique palsy, in your examination from a distance, you want to look at the maxillary hypoplasia. It's often there on the side of the superior oblique palsy in congenital palsies. But remember, congenital could often be bilateral, and you may miss this. Then in terms of the prism bar cover test, or the cover test alone, you want to look at the hypertropia in the eye, which is the paralytic eye. And you want to look at the three-step test. And I'll come to Park Bilchowski's three-step test in the next slide. That is very, very important. A diplopia charting, as you've already known. You want to do a Hess or a Lees charting, that's there. And you want to look at the torsion specifically. There is a specific need to measure the torsion in cases of superior oblique palsy. And there are ways to do that. There is a subjective torsion and an objective torsion. If you want to look at it subjectively, you can ask the patient, either you can give them a red filter in one eye or a Maddox rod, and then you can ask them to see how the two lights, when you give a point source of light, how the two streaks are differing. And you can look at it objectively as well on the synoptophore. And you can also look at the torsion on the fundus. And I'll show you one fundus picture where you'll be able to see torsion. So you should know how to measure torsion. That's important in cases of superior oblique palsy if you get in the examination, or even otherwise in your practices later on. And you want to do the vertical fusional amplitudes. This is kind of the gold medal question. In cases of bilateral congenital superior oblique palsy, often the vertical fusional amplitudes may be increased or raised than normal. This is what the three-step test looks like. So first you look at the primary position. Here you can see that there is a left hypertropia in the primary position. Then this is the first step. The second step involves the patient looking dextro gaze or levo gaze. In the dextro gaze, you can see the hypertropia is increasing in the left eye. In the levo gaze, in fact, the difference in hypertropia is decreasing. And third step is to look at the head tilt. So a tilt in one direction is going to lead to an increase in hypertropia, as you see here. This is in the direction of the paratic muscle, and the tilt in the opposite direction leads to a decrease in hypertropia. Based on the three-step test, you can actually tell which of the vertical muscles is paratic. Here you would have, typically in a superior oblique palsy, there'll be hypertropia in the palsy eye with palsy. It will increase on the opposite gaze, and it will decrease on the opposite head tilt. So you must know this test, and you must be able to demonstrate this test as well. Diplopia charting has already been covered. The specific thing to remember for trochlear nerve palsy is that you'll get vertical diplopia, and you may also get torsional diplopia, where the patient tells you that, one of these streaks is one of the colored lights that you're showing in the red-green glasses is a little tilted. So no matter how much you try to get him to fuse, because of the torsion, it's sometimes difficult to fuse for that patient. Then you have the Lee or the Hess charting, already been shown in the past. So you have a mirror septum which dissociates two screens, and then you have these fixate pointers, one of which is used and the eye is a fixating eye. The other eye's excursion is what we are measuring. And here you see on the Hess chart, you'll get torsion, you'll get an inferior oblique overaction. So it's hypertrophy, the eye is gone up. And you'll also sometimes see inferior rectus overaction. So you should again know what to look for on the Hess chart. And sometimes these are given in spotters. For management, and I've already discussed the torsion that you need to measure. In terms of management, if you're asked, you can say that, I'll be doing non-surgical management initially, which could include correction of any systemic risk factors if there are, or you could give some occlusion to prevent the diplopia or the double vision that the patient may be facing. You can teach them certain head tilting or head posturing to remove the diplopia. So if he's tilting the head towards the opposite shoulder, if I got a superior oblique palsy in this side and I tilt my head this way, the double vision will reduce or disappear. And you can give prisms. Again, this is a stopgap measure while we are waiting for it to recover, since most of these palsies may recover on their own, particularly where you're looking at ischemic causes. This surgical management is the definitive management of superior oblique palsies. And this is particularly more so in congenital palsies and palsies where there are trauma or tumors or other lesions, iatrogenic causes, surgery has caused it. And the choice of surgery depends upon the classification or NAPS classification, which is based on where is the maximum deviation in the two eyes. The basic idea is to either weaken muscles such as the inferior oblique, which is an antagonist, or to strengthen the superior oblique itself. Or you can do a surgery for torsion, as we see at the side here, where we are only working on the torsional fibers, which are the anterior fibers of the superior oblique muscle. Some of this goes into the strabismus category, so I'll stick to what from the neuro-ophthalmologic point of view. So I'm just doing a brief cover here. So NAPS classification tells you if the double vision in a right superior oblique palsy is in the up gaze and the left gaze, then we know the inferior oblique is actually overacting. If it is in the down gaze, it's class 2, where the superior oblique alone is underacting. It could be in the entire levo gaze, levo and down gazes, or it could be bilateral. So based on this, you can get this from a book. You'll know the classification, and based on that, the surgery that has to be done. So if it's the inferior oblique, which is basically doing the mischief and making the eye go more hypertropic in its gaze, then you want to weaken the inferior oblique. If it's just the superior oblique, you want to strengthen that. So I'll come to a strengthening procedure of the superior oblique, or you could weaken the inferior rectus or do a mix of different procedures. So you'll easily get a table like this in your books. You should know what surgical procedures can be done. As postgraduates, if you get your principles right, that's fine. You don't necessarily have to know every procedure here. Let's look at a few cases before we close. Here you can see that there is a hypertropia here in the left eye, in the first case, which is increasing maximally in the right dextro elevation gaze and not so much in the dextro depression gaze. So here we want to weaken the inferior oblique. So we do a procedure called the modified Elliott-Mankin, and we get this correction in the post-op period. So again, this is NAPS classification 1, class 1. In this case 2, you can see that there is actually not much hypertropia in the primary position itself. If you see, it was more of a torsional complaint that this patient had. And here we'd again tackle the inferior oblique, but we did a special procedure called the anterior and nasal transposition, where we shifted the inferior oblique towards the nasal side so that it would now act like an in-torter rather than an ex-torter. And you can see the fundus here. You could see that this macula should typically be a little below the disc here. It was above, and post-op you can see that the torsion has got corrected. It has come down. This is the normal position of what it should look like. In fact, this is slightly intorted. So you should know that it's on the lower 1/3 part of the disc that the macula lies. Another case here is a congenital third nerve palsy, both eyes involved. You can see that There is no significant hypertropia specifically seen here, but both inferior oblique are overacting, and there is a head tilt on one side, so there is asymmetry, and this is often possible. Here we had to do a bilateral surgery of the inferior obliques, weakening one more than the other. So we chose a recession in one eye and a modified Elliott-Nankin in the other. These are just examples to show you what there is, what can happen. The last two, this is again a congenital third nerve palsy in a patient who was having trouble, and again in his case we saw that the superior oblique was actually weak, a little lax, and the maximum deviation was in the down gaze. So we did a procedure called the superior oblique tuck, and now you can see that the hypotropia has completely disappeared. The last case here is the case of a gentleman. Look at the amount of head tilt. When you see a head tilt of this magnitude, you know that it is essentially torsion, which is which he's going to be having trouble with. And you can look here, not much hypertropia, mostly a torsion. And here we did a special procedure called the Harada Ito, where we are only tenting the anterior fibers of the superior oblique, which are meant for torsion, and we are strengthening them. And look at how the head tilt had corrected substantially. And this was those patients who were presented with severe neck pain as well. So all in all, superior oblique palsy, management-wise, in terms of approach, it is similar to the other palsies. Specific pointers or points I've told you here. And some of these, if you can specifically ask in your history and your examination, then you're actually bound to do very well if you get a case of superior oblique palsy. Surgical-wise, I've kept it just to give examples in this, focusing more on the neuro-ophthalmic perspective of it. Thank you.
Thank you very much, Dr. Digvijay. Wonderful talk. And the simple question is torsional diplopia common? If so, where?
So superior oblique palsies will often have torsional diplopia. In fact, a lot of times patients may not know they're having a torsion. It's when you make them realize by doing an opposite head tilt that they'll realize, oh, things have changed. And however, small amounts of torsion, 3 degrees or so, they can fuse as well. So, you don't have to always treat small torsions. It is only the larger amounts that you're not able to fuse. And unfortunately, even prisms don't work on torsion. So, in that sense. But yes, there is torsional diplopia, and there is a patient, whom I kind of made him realize that there's a torsion, and he's been very unhappy after that. He says, I didn't know it before, and ever since you've told me, now everything appears torted. So certain small torsions actually also can cause them to have distress. It's just that, they may not realize it, but it's always there.
I'd just like to welcome Dr. Prem. He's joined us and he's our keynote speaker for today. Had a question for him. Dr. Prem, are you there?
I'm here.
Yes, hi. So wanted your opinion about neuroimaging in unilateral or bilateral cases of fourth nerve palsy.
Neuroimaging is relatively low yield in those cases, and I really go from the history. If it is acute onset, if they have very small vertical fusional amplitudes as opposed to large fusional amplitudes, and now if they whip out their phone and show you their photos on Facebook and they've had a head tilt for years, then it's more likely to be a long-standing or congenital fourth nerve palsy, as was mentioned, and the yield of neuroimaging is lower. I'll discuss it with the patient, but often won't do it. But if they don't have a larger fusional amplitude, if it's more recent onset, I can't convince myself it has been there for some time, then I'll do the neuroimaging because it's important in those cases.
Dr. Sujata, any tips on how to differentiate a unilateral from a bilateral fourth nerve palsy?
Yeah, one of them is the torsion. If the torsion is more than 8 degrees, it is most likely that it is a bilateral superior oblique palsy. And also the vertical will reverse. So if it's a right over left in one gaze, it will be if it's a right hypertropia in one gaze, it will be the left hypertropia in the opposite. Say it's in the right gaze. If it's a left hypertropia, it will be a right hypertropia in the opposite gaze. That also is a pointer that it is a bilateral superior oblique palsy.
Also the head position.
Yes. Also the head posture. Yeah.
One question which the postgraduates usually asked is, if you have a third nerve palsy, how do you actually detect whether the patient has a fourth nerve palsy or not? Dr. Mahesh, you would like to say on that?
Yes. So one of the common questions is in the presence of third nerve palsy. So when the PGs answer this question, sometimes they are confronted with the question of how will you test a normal fourth nerve palsy? Fourth nerve movement. So we have been constantly teaching them how to test a fourth nerve palsy in the presence of a third nerve palsy, and in such situations, sometimes the PGs may forget to tell what is a normal movement of the fourth nerve palsy. So first, always the residents should remember how do we normally test the fourth nerve, which is depression in adduction. And then in the presence of a third nerve palsy, what do? Is there is no adduction, so we cannot test it in the test the depression in adduction. So you look for the primary action of the superior oblique, which is fourth nerve, which is intorsion, and which is best detected in the abducted position. Look for, as a patient, to look down and check for the intorsion, and it is best seen in that position because of the alignment of the globe in the abducted position.
And a lot of times examiner would ask or examiner would expect you to say that you look at the vessel because that's how it's
Yes.
Yes.
so they'll expect you to say that look at the vessel and the vessel will turn in and there is an torsion and that's how you demonstrate.
Sometimes we can look at the fundus torsion also, or even on slit lamp. So,
Preferably the vessel torsion, vessel intorsion is seen in the slit lamp, preferably.
fine. We can go to our Dr. Chitra. You want to ask any other question?
No.
Okay.
I think everything has been covered. There's one question which I had. When do you suspect a masked bilateral fourth nerve palsy?
So, see, this is again, we usually look for the amount of torsion on double Maddox. Usually, a bilateral is masked. You can mistake it for a unilateral, but if the torsion is large, then you suspect a bilateral.
And in that, the vertical alignment will be much less. So you wouldn't have a very high hypertropia, but more of torsion. That's the way to detect a bilateral.